Good morning, everybody. Today we're going to be going over the integumentary system. My name is Allison Duffy, and I'm doing this presentation on the basis of Dr. Barmby's instruction for the PathoPharm 2 course. I'm an accelerated nursing student doing my second semester here at UAH for the summer 2023 semester. So the topic of today's presentation are going to be on dermatitis and solar erythema. This is going to contain the pathophysiology and pharmacology topics of each. So to begin, we're going to be going over dermatitis. If you look on the left-hand side, here are three common types of dermatitis. First, you're going to see atopic dermatitis, also known as eczema. Below that, you're going to see contact dermatitis. It's usually seen as an itchy rash or allergic reaction. And then next below that, you're going to see seborrheic dermatitis, and this is often known as dandruff. Another type of skin condition that we're going to be going over is solar erythema, and that's also called sunburn. So the pathophysiology of atopic dermatitis, aka eczema, is what we're going to go over first. And to begin with, I want to draw your attention to the pictures on the right-hand side of the screen. You'll see a woman with her face turned, and you'll see a rash up and down her neck. That is atopic dermatitis, and that is a common presentation of eczema. And the description of this is a chronic disease that causes inflammation, redness, and irritation of the skin. Commonly, it presents as dry, cracked skin with an itchiness, a rash on swollen skin that varies in color. It depends on your skin tone how it's going to present, but they usually all contain small raised bumps. And they do have oozing and crusting, and it's going to cause a thickening of the skin as well. Darkening of the skin around the eyes, a raw, sensitive skin from scratching. And the causation of this is usually from a family history of atopic dermatitis, food allergies, asthma, or hay fever, a weakened immune system, environmental exposure such as smoke, pollen, and allergens can all cause atopic dermatitis. The pharmacological treatment options for atopic dermatitis include topical corticosteroids such as hydrocortisone, topical calcineurin inhibitors, and these are immunosuppressants used in the management of autoimmune conditions. Commonly, the medication that's going to be prescribed in this manner is going to be tacrolimus. There's also going to be injectable immunomodulatory therapy, and that's going to be called dupilumab, or the patient also might be prescribed a phosphodiesterase inhibitor, and these medications promote blood vessel dilation and smooth muscle relaxation in certain parts of the body. Oral immunosuppressants such as cyclosporin is also commonly prescribed, and this medication is often used to treat organ rejection, and since the skin is an organ, it's appropriate. Next, we're going to go over the pathophysiology of contact dermatitis. And there's an image included in this as well, and those appear as like raised patches. And if you'll see, her hand is up there as well, and it's itching. Just shows that this is an itching type of dermatitis. So the description of this is an uncomfortable, non-contagious, itchy rash caused by direct contact with a substance or an allergic reaction. Signs and symptoms of this do present as a rash, leathery patches that are darker than usual, also called hyperpigmentation, typically on brown or black skin, dry, cracked, scaly skin, typically on white skin, and they're going to have bumps and blisters, and they sometimes ooze and crust. They'll swell and burn and have tenderness. And in comparison to the previous slides that we went over, atopic dermatitis is more of a blotchiness, whereas this is raised patches. The causation of contact dermatitis is due to the exposure of irritants or allergens. Common irritants include solvents, rubber gloves, soap, bleach, detergents, and plants. Pharmacological treatment options for contact dermatitis include topical corticosteroids, and these agents modify the body's immune response to the diverse stimuli. These include clobetasol, hydrocortisone, topical triamcinolone. Oral steroids can also be prescribed, and these are also often prescribed in the form of prednisone. Physician can also prescribe antihistamines. So hydroxyzine is common in this, and hydroxyzine suppresses histamine activity in the subcortical region of the central nervous system. Chelation agents are also an option, particularly disulfiram, and it's helpful in reducing the body's nickel burden in the individual allergic to nickel. So a picture of this, an allergic reaction to nickel, is shown on one of the very first slides. If you're interested in looking at and seeing what that looks like, just go back. Up next, we're going to go over the pathophysiology of seborrheic dermatitis, and this is also called dandruff. So there's a couple different pictures on the right-hand side showing what the seborrheic dermatitis can look, and these just happen to be on the head, but they can occur on other areas of the body as well. So the description of this, seborrheic dermatitis is a common non-contagious inflammatory skin disease that presents in areas rich in sebaceous glands, particularly in the scalp, face, and body folds. So all the areas that have the most sebaceous gland secretion are going to be the most predisposed to developing this condition. So signs and symptoms of seborrheic dermatitis include flaking skin on the scalp, hair, eyebrows, beard, or mustache, patches of greasy skins covered with white flakes or yellow scales or crust on those areas as well, a rash that may look darker or lighter in people with dark skin and redder in those with light skin. So that top picture, someone with light skin has like an itchiness look to it. You can tell that she's been itching and might even be bleeding a little bit. And then the picture down below, in her darker skin, you can see these white patches, almost where she's lost that skin or it's flaked away. And it is itchy, so it's very common for these people to scratch. And you'll see bleeding in those patients as well. The exact causation is unknown. There's a possible causation maybe due to yeast, excess oil in the skin, or problematic immune response. This condition in infants is called cradle cap. So it can also be referred to cradle cap as well as dandruff. Seborrheic dermatitis can be treated with pharmacological options, and these treatment options include topical creams, ointments, and lotions, such as salicylic acid with sulfur, ketoconazole cream, clotrimazole with hydrocortisone cream, sulfacetamide with sulfur lotion, betamethasone dipropionate lotion, tacrolimus ointment. Also, they can be prescribed different types of shampoos. It's very common to be prescribed ketoconazole for seborrheic dermatitis, but there's also selenium sulfide, ketoconazole, which we just went over, coal tar with salicylic acid, and other oral medications such as itraconazole, fluconazole, and terbinafine can also be prescribed. Now that we've gone over the most common forms of dermatitis, I want to go over one other topic, another integumentary condition called solar erythema. Solar erythema is also called sunburn, so it's a condition that I'm very sure we're all familiar with. But I do want to go over it with you because it's important to address in a family sitting, and since we're all nurses, we need to be able to treat this as well. So solar erythema is an inflammatory reaction that follows excessive exposure to the sun, especially for those who spend a lot of time in the sunlight or have light skin. If you're very fair complected, you're going to be predisposed to developing sunburn at some point. So signs and symptoms of this include a position where if you spend a lot of time in the sun, its presentation will show in 1 to 24 hours after exposure. Skin changes depend on the duration and intensity of the exposure, and in most cases, after several hours of irritation, the skin becomes reddened, it develops a burning sensation, swelling of the skin, blisters filled with fluid, and the stages include an initial burn, blistering, and peeling. And the pictures on the right-hand side show each of these stages. So the causation of this is due to excessive amounts of ultraviolet radiation, mostly from the sun or tanning lamps. Individuals with light-colored skin are more predisposed to solar erythema. Treatment options for sunburn include oral pain relievers, usually NSAIDs, which include ibuprofen and aspirin. You can also take a cool bath. Topical emollient such as Cetaphil cream or an aloe vera cream or gel. But it's important to always look at the active ingredients in your aloe. Try to use pure aloe, something without alcohol, because the alcohol is only going to dry out the skin further and cause more peeling and pain. You could also use topical steroid creams such as hydrocortisone or triamcinolone. It's important to go over these medications just to let your patient know when they're on these medications what they should avoid and how they should avoid being in the sun and how long they should spend in the sun max. Make sure to tell your patient that they need to always be mindful of how much sunscreen they use and try to go for a higher SPF. So anything about 50 SPF would be great, and try to reapply every hour or so. So these medications are medications you want to avoid. The most common ones you want to avoid when you do spend time in the sun, or just be mindful of when you're in the sun, are ciprofloxacin, doxycycline, levofloxacin, cetirizine, diphenhydramine, loratadine, promethazine, simvastatin, atorvastatin, ibuprofen, naproxen. And these are important because it's also like if you take ibuprofen and naproxen for sunburn, it's also going to predispose you for further sunburn. So just be mindful of that. Also be mindful of oral contraceptives and estrogens because that can predispose you to a heightened sunburn as well. Isotretinoin or like retin A can also predispose you for further burn. Sulfasalazine and glipizide can also enhance that risk of solar arrhythmia in your patient. And that concludes today's presentation. Here are the resources for everything that we've discussed today. If you have any questions, feel free to reach out to me, and thank you for listening.